Hello, guys. I am so excited to be back. It is the Healthcare Inspired podcast here for, of course, I think it's episode 5 now, right? It's episode 5 of the Healthcare Inspired podcast, Healthcare Echo Season 2. And we're going to talk about an awesome topic today. I have my co-host, Maya Turner, back on the show. Welcome back, Maya.
Hello, everybody.
Oh, it's going to be a good one, girl. I get a little oh my gosh, I get a little giddy when it comes to credentialing and contracting because it's what I do at Healthcare Inspired. It's like my main service, and I love it. I had to talk about it at one point. Want to give the audience a little ease into my personality, get to know me a little bit, and then hit them hard with what I love, and that is credentialing and contracting. I guess I'm one of those weirdos.
You're not weird.
Yeah, I want to see, like, in our audience today, how many weirdos are out there that love credentialing and love contracting. Raise your hand, comment. I want to know how many of you out there are like me that love to dig into contracts and make sure that we're getting what we're supposed to.
That's such a big deal. Contracting is such a big deal because it makes a difference on providers surviving and the payments that they get and their relationships with their patients contingent upon their insurance and who their employer is. I see that all day, every day.
100%. And I will be talking to the audience at the upcoming Practice Management Symposium next Friday, guys. I can't believe it. It's next Friday. It's already coming.
Yes. I'm excited. That's going to be huge.
So excited. It's always exciting when I get to the week before the conference because I'm just like so pumped to get everyone's take on these amazing speakers that we have. So we'll talk about that towards the end of the show. But let's dig into our topic today. Let's talk about credentialing and contracting. So credentialing. Now, we know that there's not just payer credentialing, there's also actual credentialing of the physician. So they go to school, they get a degree, they get certified in different types of medicine. If they're an MD or a DO or whatever school they go to, they have this little paper they give them that they put it in a little frame, right? And they put it behind their desk there so everyone can see, this is what I did, this is who I am, right?
Right.
And guess who else wants to know that took place?
Everybody else who's going to pay them and see them.
Right. Mm-hmm. Like, we're going to pay you X amount of dollars because we need to, first we're going to confirm that you are who you say you are.
Exactly.
And then we're going to figure out, okay, like, it's like a series of questions, right? I mean, I'm doing one right now. I'm doing a huge project for a hospital system. Yeah. And let me tell you, I have done numerous credentialing and contracting for smaller practices, mid to large practices. But hospitals, they're fun. I will say I love doing hospitals because there's so much going on. Yeah. And it's just fun to dig in and like figure things out. I love it. So it's a very different dynamic because you have to make sure that obviously they want to know which hospital you are privileged at. They want to know, what steps you've taken to, of course, go into this arrangement. When did you first go into the arrangement with this hospital, these organizations? So if we get a claim and it says that you performed it at this hospital, do you have privileges to do service at this hospital?
Yeah. And I think a lot of times when you're dealing with privileges at a hospital, that makes the difference on how the patient is going to be serviced, the outcome of the procedures that need to be performed, contingent upon the location, because privileges can be revoked based upon a physician's behavior. So, their timely documentation, I've seen it. And so when you're dealing with privileges and being credentialed and how all of that kind of comes into play, it really goes hand in hand because it really is contingent upon A, the physician's ability to perform the service, and B, the ability to maintain the contract by doing what they're obligated to do, which is see the patient, document in the record, and not have any adverse effects from the care that's being provided. I mean, that's kind of like the bottom line when you're dealing with credentialing in hospitals, and based upon their behavior and that relationship with the hospital would be contingent upon if they can continue to work with that hospital. Some physicians, and I've seen it, have to find alternate locations because they cannot maintain and or obligate themselves to their obligation to perform the work.
100%. And I think it's important to stress that, you know, the people that do this at your facility, they're not the bad guy.
No,
And they're often thought of as like, oh, there's credentialing people. And I know my friend Tara, we kind of joke sometimes, they're the Mikey of the organization. It's like go get Mikey, he'll take care of it. Mikey will do this, Mikey will do that.
Give Mikey,
you know,
everything.
so sorry for all the Mikeys out there, but I wanted to say it's like that's what happens. And like you're like the one that, oh, they'll take care of it. But let me tell you, that is not how it should go. If you've ever done credentialing, you know that there's a lot of things you can't do because, you know, you can't sign the contract. So you got to track down the physician. You got to say, okay, I need your signature. And then there are things that they won't let you in. PCOS, for instance, the Medicare system to get credentialed with Medicare. Like that's like Fort Knox trying to get in there. And then you have CAQH, right? The database you have to manage.
Yeah.
And it's just insane. And nowadays, you know, we have nice, awesome software out there. Shout out to MedTrainer. We love you. We love you.
Yeah. They make
shout out.
Easy. Yes, very, very easy to do
but
that.
But I still see people doing it on paper. And, you know, I'm not opposed to the paper process if that's the way you work. But a lot of things can go wrong if we stick to a complete paper process, especially with credentialing. When most of the payers, right, everyone's digitized, and the way you communicate information is through the computer, through digital methods, that it's almost impossible to manage on paper. Especially what if you leave the organization and no one knows what you did?
Right. Yeah. Yeah. I mean, and I've seen and I mean, and I hate to say this, but credentialing, when you leave the organization, could be just as time consuming when you get them on board. You know, it's crazy. And then, you know, what I deal with a lot is once a provider leaves an organization, then they want to go into the locum thing, you know, and I won't even get into that because you have to have the contracts can't be active. I mean, there's just so many different things that you have to deal with from a credentialing perspective, and making sure that whoever it is that's handling that keeps all the I's dotted and all the T's crossed. Because if it's not, and then you have to follow up behind them, it's more labor intensive because you got to find out what they didn't do to keep up with what's current and what to make it right. So there's just a lot to consider when you're dealing with credentialing, whether it's onboarding, offboarding, making people aware that a provider is leaving a network. When you, I mean, that's yeah, it's very labor intensive, and you know, you really got to have a love for it in order to stick with it and do it all the time, because it could be time consuming, and you're chasing, and you know, once you're chasing, but then you have to find a way to make sure that they want to participate and answer you, right? And you know, it's a very labor intensive process, but at the end of the day, when you are successful, it makes it all worthwhile.
It really does, because it's a difference, and it's not just about the provider, it's about the patient.
Yeah.
You know, the patient is that's why we're here today. We're here to talk about the impact on the patient. That's the purpose of this episode. So I wanted to really dig in and talk about the patient, because I'm a patient, you're a patient. You know, there was a time this last 6 months when I was in transition, started my own business, and then like trying to figure out the insurance thing. And so for a good 6 months, I was without insurance. So, you know, my voice is like, okay, my thought is like, do I go to the doctor, pay out of pocket, or I wait till January? Can I wait? And so it's always that thing. So people are in that bucket too. A lot of entrepreneurs that don't have insurance through an employer, they're footing the bill for it. So it's a real impact for real people who are just trying to take care of their families, take care of their health, so they can take care of their families.
Right.
And so we think about the process that they go through. Okay, I signed up with this insurance. I got a copay. I've got deductible. I know, but I'm going to have like this copay for my specialist, this copay for this. I get to the doctor that I love and they don't take my insurance. Heartbreaking.
Yeah, and I think that's part of the conundrum when it comes to networks, credentialing, and things like that, because you really are gambling, and then you got to fall in love all over again with your
Yeah.
providers because they're not part of the network, and you love them so much, and you like, do I really want to risk paying out of pocket? I can't do that, so I got to find somebody else who's just as good, and all providers are not created equal, and all care is not created equal, and not all staff that work with providers are created equal. So you have to deal with that, and that's just part of the gamut, where we don't have and it's something that left to be desired, where we don't have a standardization across the board for insurances. It's always the network that they use. It's always the insurance that they use. It's not across the board. If you're this insurance, if you're this insurance, if you're this insurance, it just doesn't work that way. And you wonder if there ever will be some sort of standardization across the board for insurances, whether you're a government or commercial payer, because it does make a difference on how these patients can see the providers that they've grown to love.
I
And
know.
now you have to sacrifice going into an office, and if they have the insurance, and what you have to pay and the amount you have to pay based upon the tier that they are. I mean, it's even based on tiers now. So you gotta, I mean, there's just a lot. When you deal with this for a long time and being a patient, you want to get the best optimal care, and you want to be able to see the providers that you want at the copay that you want. You don't want to pay $100 copay because they're tier 3 versus tier 2 versus tier 1. So it's just a big, big, big puzzle, and you wish it wasn't.
Yeah. And I'm really glad you said that, because I worked with a company at one point where the staff didn't know about the tiers. And so they told the physician they were in network and they weren't. They saw the patient. They did a really expensive eye surgery
Yikes.
thinking they were in network. And again, yeah, who's upset? The patient and the physician, because they expected the organization that was verifying things for them,
Yeah.
or the person that was responsible to make sure they were network, ultimately, yes, the provider is on the hook, but if they're paying you for a service, they expect you to give them accurate information.
Man.
And you don't know these things, then what are you doing? Why are you saying I know when you don't?
Yeah.
So it's a big problem.
It's a huge problem, and I think we talked about this last season. The patient wants transparency. The patients want accuracy. They don't want to go into the office knowing that their provider is out of network, or once was in network, and then they're negotiating to get back at network, and they're not tier 1 when they first started, they're tier 2. Just like when your formularies change with your prescription coverage. That's a big thing too, right? And that also is dealing upon the type of insurance that you have, and the contracts with the drug companies. We're not just talking about physicians' offices. It's the whole thing. My insurance company covered one drug that was $10 a month, and then they stopped covering it, and it turned out to be $1,300 a month. So that's a huge difference, and the patients are angry because they make these significant changes, or the employer decides that they don't want to pay for it anymore, or they don't want to pay for this type of service because they're quote unquote overutilizing, right? Or they're a high risk provider. So you're dealing with all of these different variables. It's almost as worse as politics, right? Because you're dealing with all of these different variables in order to get coverage, or to stay with something that you can afford to or maintain. It's insane. It really is.
Yeah, and guess what? Because of this rigmarole we go through, the patient gets sicker. And
Yeah.
we talked about social determinants of health. This is a big connection there, because
Yeah.
maybe because they don't have access to the right budget for their drugs, like they can't afford this drug. So
Yeah.
they're like, okay, well, I'm going to ration this. I need to eat today.
Yeah.
So I'm going to just ration my medication a little bit. They get sicker.
Oh,
They end up costing more when they get to the hospital. So
yeah.
insurance companies, what are you thinking? Like
Yeah.
you're costing yourself more in the long run because now they're sicker and they're costing the hospital more. They're going to shell out more claims to you for
Right.
this patient that would have been less money for you to cover in the first place.
And it's heartbreaking because we're at a day and age where you're paying for the physician, you're paying for the care, right, with copays, and then you have to pay for the maintenance to keep up your care. And so you're dealing with three different dynamics to keep up. So there's no wonder that social determinants of health become so prominent because you're dealing with insurance issues. You're dealing with how to ration, how to maintain, how to survive. So, and I'm not really sure if that's, you know, the direction that we're going with our conversation today, but at the end of the day, it's real life, right? Can you afford it? Is it something that you can maintain? And how the credentialing kind of plays a key factor in everything that's related to the care and the insurance that they have. So it just really
When
is. Yeah,
yeah.
yeah.
Yeah, I'm gonna get a little emotional when I think about this because I think about real people that, and I watch a TV show, I binge a show that's like super old. It's
Yeah,
like from before the pandemic. And it's amazing to me what the people in Hollywood, the people they used to foretell what we're going through right now. I mean, they didn't know, but
right.
they get like consultants that come in, right, that understand healthcare, understand different things that happen. And it's amazing to me how they foretold all the things that we're seeing right now. And it's just like, what in the
Like the two movies that we love, John
I know.
Q and The
Yes.
Rainmaker, right? And when you think about those two movies, that is the epitome of what we are going through even today. And those movies are 20 years old. They're 20 years old.
Yeah.
And it's just like, you should talk to your congressman. Uh that was a move that was the line that Anne Hesh said to
Yes.
Russell Crowe, and it's just like, what do you say to that? Because it's still relative. It was all about the kid being able to get a transplant. He lost his job, he didn't have enough hours, he lost his insurance, and now he's trying to get a necessary service for his son to survive. So he goes to the extreme by holding an emergency room hostage. How do you deal with that? How do you deal with that level of extreme to get care? And
Mm-hmm.
you know, that movie is so underrated.
Oh, it's emotional when I watch that movie. Like it still gets me when I haven't watched it in a while. Maybe I'll have to dig it out just to feel it again because it is such a good one.
Oh, girl, yeah, and okay, well, yeah, we're kindred spirits and that kind of.
Well, I want to tell you. Okay, the show I'm talking about is Madam Secretary. I don't know if you ever watched it,
I've
but
never
it's
seen
like
that one.
I've binge watched it like I don't know how many times. And
That's the
I don't
one
like.
that's
I'm
Tia
not into
Leone, right?
politics. I'm not political, but I just love her as
That's
a
Tia Leone,
person.
right? Tia
Yes, I
Leone.
just think
Okay,
she's
okay.
fabulous.
I've seen
If
it. I've seen the. Yeah. Okay. Now you got to
if
get me.
ever there was a Secretary of State or a president like her, I mean, like she's just so great. But I just love watching her and just how she just tells you like it is. She knows her stuff. But there was one scene recently that I was watching. I think it was season 5. I forget what season it was, where there was an actual outbreak of a pandemic. The show ended, by the way, in 2019. That's when it ended officially, right? So it was like season 5 would have been 2018-ish, maybe. So not on our radar, maybe, I don't know. But it was so interesting how they kept talking about what if there was this pandemic that happened and how are we going to, mandate certain vaccines and all this kind of stuff. And I'm like, watch, oh my gosh, because I hadn't watched it in years. And so
Is that on Netflix?
it's on Netflix, yeah. So I hadn't watched it in years, and I was like, what? And it
Yeah, we
was just
have
so
to have a Zoom call
interesting.
just to watch it together to be like, what?
I know. I'll find the episode and I'll let you know what it is. But yeah, so that's the stuff that I'm like gives me goosebumps. That I'm like, wow, like this people are thinking about the future, what could happen, and here we are, what 3-4 years later, thinking about that. But again, it's about the patient. It's about what they're going through. So we really want to encourage you as a patient. We're talking about transparency these days. Get to know your policy. And I know it's hard. I know it's a lot to read, but ask good questions. When you go to the office, ask if you're in network. And then also take it a step further. I always tell my friends this when they have surgery. They always call me to make sure that I give them advice on insurance. And so my best friend in the whole world, she's going through breast cancer right now. And just like, it's heartbreaking. I'm going to actually go and visit her this afternoon. We have a date to visit and hang out. So, but the first thing, I was actually at a conference when this happened. So she calls me and I'm thinking it's going to be exciting news she needs to tell me, because she was like, I have something to tell you. Can you have a minute? And I said, yeah, sure. And I was not expecting that. And so I went into like mom mode and like protector mode right away. And I was like, do this, do this, do this.
Yeah.
Call them every day to make sure the authorization goes through and that it gets done for her MRI and all that stuff.
Time, right? For the time span that is needed. Don't underestimate the amount of time, because that could be undervalued too.
Yeah. So I always tell patients that come to me that are my friends and family, it's like, just be on it, be as responsible as you can with the process. Don't be afraid to ask questions. Yeah, you're not a professional in that world, but you have a right to know what's happening to your information, where it's going, and also the status of everything, because you don't want to get stuck with a bill. You don't want to go through that surgery or that procedure if you don't know it's covered.
Right.
And if they can't cover it, find out why. Find out what the deal is.
And I always like to think that your health insurance is like your bank account. It's like your health bank account. If you maintain your bank account and you maintain your money, you should maintain your health insurance and understand all of the things that are related to that. And if you consider all of that when you are thinking about your care, then you're going to take and pay close attention to the care that you provide, because at the end of the day, it's going to be about the money. But one is dealing with your health and the other one was dealing with your finances. So it's basically the same thing.
Exactly. Well, real quickly, I want to just jump in a little topic here. Just a reminder, I'm not going to go into all the ins and outs of contracting because it's a process on its own. So if you have questions about your contracts, both Maya and I can help you. We're both consultants that do contract reviews and negotiations. So if you have looked at your contracts and you're like, oh my gosh, they haven't reviewed since 2006, we have a problem. Because as you might realize, things are worse now and it costs more. And so, yes, the payment for like a 99213, for instance, for a mid-level E&M visit, if you're on a 2006 contract, if you look at today's rates, I mean, it's not great, but it's still more than it was in 2006. Yeah. So you're losing money right off the gate. Oh. And, you think about your specialty, how many 99213s do you bill? How many level 4s do you bill? I mean, I work for an ENT provider. I'm a consultant for a practice, an ENT practice. And we actually looked at their data just to see where their levels fit.
Yeah.
And they are across the board for 2023. They were across the board, all 3s and 4s mostly. I mean, they had a few 2s in there. Very rare to have a 5 there. But I mean, on the hospital side, they may have had some high level things, but on the office side, they were 3s and 4s. That's the bulk of their revenue on the office side. And I was like, you got to review your contracts because we need to see where you're at. So again, that's information that you need to know. You need to know, for instance, for your E&M visits in your contract, what does it say you're reimbursed at? A lot of commercial carriers are stingy right now, and to get 150% of Medicare is very rare, although it does exist.
It does.
So if you already have that, that's great. But if it's based on 2006, is 150% really that great?
Right. I mean, and I also think that it makes a difference on, what the UCR rates in the area is,
Exactly.
Because you have your RVUs. That's my dog King. Hi,
oh,
King.
Hi.
he's saying hello to everybody, but
I love it.
Yeah, I mean, I think as I was getting, your UCR rates and your RBRVS relative resource-based relative value scales are the things that are considered overhead expenses, your malpractice insurance, and you want to make sure that at the end of the day, your contract either represents what you can make in the front end or write off on the back end. And if you're not considering those two dynamics, you're going to lose money, specifically when it relates to things that are above Medicare and the UCR rates are in your area. Because if you're not considering that, uh, you're going to find yourself in the hole. And that's why a lot of providers are not surviving, because they don't review contracts. They don't think about the resource-based relative value scale. They don't think about renegotiation or what their reimbursement, their work RVU reimbursement is, especially if they're contracted with, a hospital or with a network. So you have to think about all those different things. And from a private practice perspective, if you're a proceduralist,
Mhm.
how much you're getting paid for performing that procedure for that network, how much you're getting for rounding at that hospital because you're credentialed, and if there's going to be some back end coverage for covering for physicians who are not able to do it on an emergency basis. So, I mean, just
Mhm.
like your laborists, when your laborists are covering for an OBGYN that's on call. So you got to think about all these different things on the back end that is going to help you maintain, survive, all those different things that make a difference on how and what you can afford, what you can write off, and your relationship with your payers.
Exactly. And if you're part of an ACO and you know they're going to give you a really great rate, what
Yeah.
happens when the ACO decides, okay, we can't negotiate anymore with this particular payer, and they
Right.
drop it? Like I
Right.
said, this week, I let everyone know there's a couple different hospitals in Arkansas that have dropped United Healthcare.
I,
So if you're in a community where all the patients go to that hospital, like they don't have a lot of choices, then if you're like a single specialty that's really unique in that area too, you don't have a lot of choice either. But you know look at your payer mix, look to see what's happening. And also, when you go into an arrangement like that with an ACO, do you know what they're doing on your behalf? Do they understand your procedures? Do they
right.
understand that you
Yeah.
have very unique services that you need
Yeah.
to be compensated for? Get out the calculator and calculate your staff, calculate the supplies you use, the machines that are all the stuff that go into doing that procedure. And if they can't get you to cover that, then is it worth it?
No, exactly. And I think that's part of the issue. Like that's why I mentioned proceduralist versus non-proceduralist, right? If you are a consultant that doesn't do procedures, but you specialize in a service that's underserved, then
Mm-hmm.
you should get more money for your E&Ms. You should get more money for
Yep.
your services as a consultant. So, I think it's all about branding,
Mm-hmm.
and how you are putting yourself out there as an asset for the network, and how you can create value. Can create more patients by your specialty and being involved with that network. So it's all about knowing your value, knowing the dynamics of what you can perform and provide for services that may not have it at a different hospital. So you got to think about all of that stuff and how you can benefit from it as a provider.
Exactly. So if you have questions about contracting or credentialing, let us know. We're here to help. We love helping physicians and hospitals make more money because we don't want you to close. We
Right.
want you to stay in business because guess what? Our families, us, we want you to stay alive because we need you.
Yeah.
So
Yeah.
trust us when we tell you we can help you. And if we can't help you, we'll let you know. We'll let you know where you're at in the process and what your options are,
Right.
because you have options.
Right.
Whether you decide to go join a larger system, that's a choice you could make, but there are very real decisions you can make to stay in business that you
Right.
might not be thinking of.
And I think,
So
I'm sorry, go ahead.
no, you're good, go ahead.
No, I think one of the things that physicians or even private practices don't realize is that they do have a say. And they do need to understand that if they are looking to be in business, you can't do everything yourself, right? You have to hire or be around people who know what's best for your practice. You can't do everything yourself. And if you don't think that you can, then talk to some people. I mean, and people think, well, I am on my own now and I have to do everything on my own. No, you don't. There are people that are out there who are happy to help you. I would never forget at HealthCon, there was one physician who was in the Modifier 25 room and she did all the billing. and she was in there talking about modifier 25 and how, and we were like, well, why are you doing all this? Well, it's just me. And we're like, but there are people who can help you. The money that you're losing is the money that you could pay someone to do it for you, that you don't have to spend so much time to attend these types of conferences, because you have someone that knows your interests, knows you, and is keeping you in mind when they can think about how much money you can make, rather than you spending time away from your patients or your productivity for the month to make that kind of money that you're losing by attending this conference. So you don't have to, I mean, you can learn the business yourself, but there are people who can help you understand the business of medicine, because you were there to practice medicine, not in addition to the business of medicine. So it comes hand in hand, and they're very parallel to each other. I can't hear you.
So we have a viewer that has a question. So here's a question from one of our listeners. How do y'all feel about cash pay networks? What do you think, Maya?
Cash pay networks.
I think he's referring to those that are cash pay only, like those like physicians.
Oh, you mean like, oh, okay. Well, I've dealt with FQHCs before, and FQHC is a federally qualified healthcare center where they have what's called a sliding scale, and it's almost kind of what you're dealing with cash pay networks, and they go by the income of the patient. So when you're dealing with cash pay networks, in my opinion, you still make money, but you're still losing money, because you're not necessarily getting the true value of the money that it costs to manage that patient. What if that patient is a frequent flyer and they see you every week and they're only paying $20 for the visit, rather than paying what the average cost is, which is $80? So you're going to lose $60 every time you see that patient, because you're honoring the $20 amount. And so, I guess it depends on how, needy that patient is, but I don't feel that cash pay networks are going to be beneficial across the board. It's beneficial for patients who are there occasionally, but not for people who are frequent flyers, because they're going to take advantage of that.
Yeah, and then also we have concierge physicians. Like going back to our previous discussion, like when a provider leaves, I was heartbroken when my physician, Dr. Brian Malloy, I love you, and because he went concierge, it was hard for me. And so they offer a payment plan, like a monthly fee you can pay to still see them. And some people just don't want to do that because they have insurance through an employer. So it's like, to them, it's like, that's the benefit they want to use.
Right.
And so I understand that some physicians are forced into that. That's their preferred method of getting paid, is direct patient care. That's what they want to do. They want to just have them pay them directly. And that may work for primary care, works really great, maybe.
Yeah,
but for surgeons,
no,
not for surgeons. I'm sorry. Like maybe the office stuff, but injections are expensive, and then you get into, like, obviously surgery, you got to go to the hospital. So yeah, the hospital takes it, but
drugs, yeah, that to me, that and I'll do a comparison, because I always like to think of comparisons, right? For my dog, preventive medicine is expensive, and then they offer this for preventive medicine because you're paying X amount of dollars per month. That it's going to be related to shots, and if you have, but that's only when it's needed. But when you have things that are, across the board and more frequent, then is it really, I mean, you're going to get a bargain, but you're doing so much more. So you're kind of risking, in my opinion, how that's going to be valued for your practice. For the patient is already valued, but for your practice, are you going to tend to lose money? So you got to, look at those types of cash pays that is related to that.
Yeah, and I agree with you. I think it's Omira. Thank you for commenting. I agree. In a lot of areas, these boutique physicians and these, I guess they call them, or concierge, like, they're paid well. And there's a great population of people that will do this because they don't like the deductibles. They would rather go to a physician where they're like, yeah, I just need this. I don't get sick very often. I just need my prescriptions refilled.
Right.
I don't need a lot of stuff. But for your really sick patients who have a lot of comorbid conditions that have a lot of medications and a lot of things, they need insurance. Now, there's a lot of things that go into that, but yeah, overall, I think if you go into that, you're going to have a certain patient base that's probably going to be a little bit more fruitful for you than others. So in some areas, yeah, in some of our smaller communities, it may not work so well, because in these rural communities, you have people that don't make a lot of money. There's not big employer systems in their area where they make a middle class wage. And so they're not going to be able to go to you because they need their insurance. They need government funded insurance. So again, it depends on where you are, what your situation is. So that exists out there. I do agree. And so for those that can do it, then I do think it's great.
Sorry about my dog.
Not a problem.
Sorry about that. And I to get back to your, the boutique physicians. I mean, I think about the plastic surgeon, right? You don't really need a plastic surgeon, but they make good money because most insurances don't cover plastic surgery. So,
yeah.
I mean, so that is going to be paid very well versus a family practice provider who has a higher population of older individuals who are on a limited budget, that need the care but can't afford the frequency, So, what kind of boutique physician was it? Were they a family practice? Were they internal med? What was their population? Are you dealing in an area where they're very high in income versus low in income? What kind of area is it? So to me, that all depends on how well that boutique physician will do.
Exactly. Well, I hope you all enjoyed this discussion on contracting and credentialing. I wanted to give you some coding tips and kind of like a reminder of some of the things that we saw in 2024 that hit. So if you remember, one of the things that we saw, of course, previously was that there were some refinements that were made to just the language and the time ranges. For certain references to the time. So it was like really great, I think, when they told us that they were going to remove the range and just over this amount. Right. It was a little easier for physicians to understand that. Like, we're going to tell you how much time we spent. That's all we want you to tell us is how much time did you spend with that patient, right? So if you were going to bill by time, of course, you still have to follow those official guidelines of tell us what you did during that time. You don't just get to say, I saw the patient and I spent this much time. Like, that's not good documentation.
Right. No, greater than or I spent a considerable amount of time. That doesn't help at all.
Yeah. So just like since you can choose, right? You can choose whether you bill by MDM or time. You still have to have the elements there that if the MDM is better for you, you can still capture it. So you still have to have all that. And we'll base the time off of the time you document as long as you tell us what you did during that time.
Absolutely.
And it can't be time that your staff spent. This is you. You're getting paid for it. It's your NPI on the claim form. They want to know you personally, Dr. Smith or Jones, what did you personally do during that time?
Right. And the definition for CPT is 1 minute per clinician or per physician. And so even if you are, having a conversation, only one of you are able to bill. And it's the one whose office they're sitting in when you're having those types of conversations. So you got to be real careful, especially when it comes to time. That's an educating point that I cringe a lot when they say, what can I do, what I can't do, and what's better for me. We're going to audit to be what's your best advantage. If it's MDM, then we're going to look at the MDM and we're going to look at what you did. If it's the time and you spend greater than a certain amount of time, then we're going to go by that. But it all is contingent upon what the documentation is and how well you've accounted for all of the time that you spent versus MDM.
Exactly. And so every time you review your CPT book every year when it comes out, it's really important. I encourage all of you to dig into the E&M section very carefully. Read everything, because every year I get all these questions from people and I'm like, did you read the guidelines? Your question is answered in the guidelines. Let me show you where. And so, again, we know that CPT and CMS have this, I guess, this little nice little conflict that they go on and on with the.
Oh my gosh, I won't even go there. Yes.
The prolonged care times, and
it's so funny. It's so funny. And when I watch the symposium and I see the MACs and I see the looks on their faces, and it's just like, oh gosh. I mean, what are we, can we just all get along? But I mean, I think there's always going to be a conflict, because there's, from a government perspective, they have to think about conserving the dollar. And the other perspective, they're thinking about what the physician's work is. And I really like, if you've ever had the opportunity to go to the CPT editorial committees, those are really where you see where the code and the physician's passion go to work. And see, and then they value that dollar. And then you have the RUC committee who actually values that dollar and then compare it to what Medicare pays, because they're all about conserving the dollar. It really is a huge dynamic of how that all works into place. So if you've never had the opportunity to listen to the CPT editorial committee meetings, you should try to listen to, because it's really where the groundwork and the grunt work really take place.
It really, really is. And it's important to know where they stand, where their thought process comes from. And so whenever you see a new change, even to just the wording, to make it more clear and I guess more concise, so we understand it better. Because we're the ones having to read those guidelines to make sure that they're carried out correctly. So we need to understand it too.
Absolutely.
And then there was a slight kind of, I guess, wording change just to make it better align with what CMS has always said about our same-day discharge codes. So those are the codes, the 992, 34, 35, and 36. So when the physician that is admitting the patient and then also discharging them the same calendar day, that is the rule, right? If you admit and discharge different days, that's, again, pretty simple. It's an admit and then a discharge code. That's easy. But the same calendar date, they said, we're going to combine that payment for the work you did that day into one code, and it's based on the level. So you're going to just do that.
Yeah.
But remember, CMS also has a rule, that the 8-hour rule.
Yes.
So what happens?
Less than 24 is the verbiage. Yes.
Yes. Greater than 8, less than 24. So if it's less than 8, what happens, Maya? You forget. You forgot.
I was just like, wait a minute. It's just one charge.
So
sorry.
It's okay. Okay. So less than 8 hours. So let's give you an example. Okay. Let's give you an example. Okay. So the patient arrives and discharged on a different calendar date, but let's say they arrive at 11 p.m. and they're literally there. So we're going to report the code, the 99221 to 23 on the discharge date, because that's really what they're saying is happening. So if it's the same calendar date, we're just going to be, all we can bill is what we did. We can't bill a discharge because it have to have both.
You have to have 2 notes to represent 2 services that were performed. They can't, ideally you want 2 separate notes. There should be an HMP and there should be a discharge note for you to bill the same day admission discharge, because you're performing 2 services and you want 1 charge. But you got to also be careful with same group, same practice, dilly-doos.
Exactly.
Because it can get really hairy in that regard about who's rounding, and if they're not the admitting physician, you got to be really careful about that when it comes to same-day admission discharge, and if that's even billable. Because I've seen where you've had different practices who are rounding, and if they're different practices, they can do it, but they got to be different specialties, right? But if they're of the same specialty and it's a different provider, you got to make sure you have some safeguards in place for audits, because that could be really, I mean, it could be really challenging to prove that. Yeah.
And I'm going to keep it really simple for you guys. Just, the insurance company wants to know who was responsible for the time spent on that patient on that calendar day. Yes. And so you may have multiple providers, but you have to know, like, they're one physician per day. one consultant per day, one
Yeah.
admit per day.
Yeah.
So one CPT per patient per physician per day
Right.
for the E&M, right? So they want to know that. Now, CPT has their own language on things, but remember, we're talking about what is reimbursable. You may have a code created and a guideline around it in CPT, but you may not get around that with CMS. And
Right.
a lot of times you're not going to get around it.
Right.
So let's repeat that. The patient arrives and is discharged on the same calendar date, but it's less than 8 hours.
Yeah.
All you're getting is that admit because that's all that you can get. So
Right.
that's all they're going to pay you for.
And also you have to think about the initial care too, where the new rules for CPT states you could get one initial visit per admission. So you got to be real careful about how that verbiage is and how that relates to your practice. Because again, if it's less than 8 hours, you're only going to get one charge. But same group, same physician. CMS thinks of it as one physician. They're being paid as one physician. So make sure that there is a policy that your organization follows, and follow the policy that creates less risk. And to me, that's CMS every day, all day.
100%.
Yeah.
Every day and twice on Sunday.
That's it.
Yeah, I'm going to tell you, like, I have so many consultant friends and like Terry Fletcher, we go back and forth on this all the time, and Christine Hall. It's like, why would you not want to use CMS criteria when they beat out the payers every time on logic?
Every day, the mother of all payers. Every day, all day. Because that's
exactly
the payer mix. That's the payer mix. That's 60% of everybody's payer mix in most instances. Unless you're a plastic surgeon, then
yeah. Well, you're going to have a better opportunity to create, like you said, less risk if you go by CMS. Either way, yeah, the payer is going to maybe have their own rules, but if you stick to your policy on that, you're going to be at a higher level of scrutiny anyway. So you're going to be well within the guidelines of the other payers if you follow CMS. It's just the way it is because they are more strict.
Right. And I also, would like to put out there that most private practices do not have a payer policy that they keep in place. And we know this, and it's a problem because that's why they lose so much money, or that's because they're so at risk with so much money because they don't have a policy in place. But if you work for a private practice, have a policy because you want to keep the dollar. You don't want them to come back and say, oh, you know what? We paid you X amount of dollars and now we're going to take that back because you didn't do X, Y, Z. I don't care how small or how large your practice is, have a payer policy that is involved with less risk. The larger the practice, the more risk you're going to be by not having a policy. You need to have a policy in place because if you don't, you might as well just gamble the money.
Yeah, you might as well go to the casino, go to Vegas and just gamble it all away. And I'm going to be in Vegas in April, by the way. So I look forward to seeing you there.
And I will be there too.
Exciting. Well, just to leave you guys with some motivation, one of the things that we're really, really encouraging people to do is attend our practice management symposium because we know some of the people out there that truly don't get enough education is our practice managers. You have a lot on your plate with HR, marketing. You have to deal with physicians and their questions and contracting and credentialing, the revenue cycle, dealing with employees that just don't get along. I mean, sometimes that is just like all you do all day long is put out fires between staff. That's too much drama, right?
Yeah.
So how do you deal with that? How do you deal with the patient engagement problem where your staff is just not quite engaging with the patient? The patient is just being rude to your staff. How do you get yourself in there and really create an environment that patients are happy, the staff is happy, and they can work together? So These are things that, forget coding and billing. This is a real problem that physician practices are having because they need to give their practice managers training because they are just drowning with so much they have to do. So the QR code is there, guys. It's February 16th. It's next Friday. The 20% off discount ends this Friday. So please, 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 it really isn't that expensive, but we give you a little bit of a break just for the end of this week before the week of the conference. So please, please, please Join us. It's going to be great. We have Rhonda Buckholes. We have Maya Turner, myself. We have Bertram Lantico, who's going to talk about HR.
Yes.
We have Vanessa
Amazing.
Moldovan.
Yeah.
Oh my
Yeah.
gosh. Check out her podcast, For the Love of the Revenue Cycle. You got to check it out. And of course, we have the amazing Jessica Miller going to be talking about technology and AI.
Yes.
And then my favorite people that I know that I respect so much, Terry Fletcher
Yes.
and Susan Wahlberg, were joining me for a compliance panel. I'm so excited.
Yes.
And then we have Christine Hall that's going to give us her take on telehealth compliance. So much fun stuff coming at you. You don't want to miss it. I mean, just one of these presentations is worth the cost, and you're getting 8 CEUs. I mean, I'm wanting to give this education because it's so needed, and I know budgets are tight, but at the same time, this is such valuable information, and
Right.
you got to invest in yourself, invest in your practice. This is what you need.
Yes. I also think, part of the issue is that we're so busy with the day to day, we don't take time to invest in the knowledge and this is something that could be contributory for everyone who's involved with the practice. And if they're involved, like your insurance verification, they could be involved, your front desk, all of that stuff. And if you really want to have a return on investment, this is the symposium to attend. It really is going to be worth the return on investment on the dollar, because it's going to mean that much more to your practice, because you're going to make that much more money if you just take the time to listen.
Yeah, I mean, pretty much everybody coming to this conference has at least 20 years of experience in healthcare or more. We've seen the headaches. We work with practices who have been successful, and we know what their challenges are. We can share with you. And again, everyone's invited. It's not just practice managers, because we know that they're busy sometimes. Maybe they want you to attend and share with them what you learned, because you're going to learn about revenue cycle. You're going to learn about things that you need to know just for your job. So we're going to talk about reporting, KPIs, just business intelligence, things that are happening, which is understand how to read reports that managers need to know. A lot of great stuff. So I hope that you'll join us next Friday all day. We're going to have such a great time. So thank you guys for joining today. We're glad you joined us for this episode. Stay tuned for more episodes coming at you. And I have a special bonus episode this week with Dr. Katie Deming, who is an amazing radiation oncologist, wonderful woman. You want to check out her podcast, Born to Heal. It is fabulous. So check that out tomorrow at noon Central. We are going to be chatting with Dr. Katie Deming on radiation oncology. So check it out. We'll see you next time, guys.